Hello, this is Matt Janucki, and you're listening to Inside Men's Mental Health, brought to you by Psych Sessions. Here we explore this thing called masculinity and its impact on men's mental health, relationships, and communities. We'll learn together through conversations with thought leaders, innovators, and industry experts. Our conversations will also help us understand how these experts became interested in men's mental health and the ways their journeys have made them who they are today. Dr. Andreas Walther is a senior researcher for science and teaching in the Department of Clinical Psychology and Psychotherapy of the University of Zurich, and clinical psychotherapist with the Outpatient Clinic for Cognitive Behavioral Therapy and Behavioral Medicine of the Psychotherapeutic Centre of the University of Zurich. This conversation centered around depression in men, and Andreas worked to better understand and treat men suffering from depression. He opened up about how this journey began with his father's own battles with depression, and how this influenced Andreas' drive to help men experiencing similar struggles. We also talked quite a bit about the treatment he's developing to help men with depression. Just a quick note, this conversation does include references to suicide. Thanks for listening. Welcome to Inside Men's Mental Health. Today I'm with Dr. Andreas Walther, who's a senior researcher for science and teaching with the Department of Clinical Psychology and Psychotherapy at the University of Zurich, also a clinical psychotherapist in the Outpatient Clinic for Cognitive Behavioral Therapy and Behavioral Medicine at the Psychotherapeutic Centre at the University of Zurich. Andreas, great to be with you today. Thanks so much for joining me.
Hi, great to be with you.
One of the things that I'm always interested in when I have these conversations with folks is how they came to this work, specifically like men's mental health work, and really would be interested in hearing a little bit more about this with you, how you got started in this.
Well, I guess it was definitely a important situation when I got the first time into my boss's office when I started my PhD. She's called Ulrike Ehlert, and she's
Hmm.
a classic CBT psychotherapist, psychotherapy research professor,
Yeah.
but also very grounded in stress research.
Okay.
So she was also examining a lot the biological basis of stress and stress-related psychological disorders. And she has done many projects also with women and pregnant women and how they react to stress during pregnancy, menopause, so all these women-related issues.
Yeah.
And I walked in and she said, great. Yes, because I wanted to talk to you. I needed a man for this project. Now I want to shift my focus also to men. So you need to do
Okay.
something with men. So she told me there needs to be hormones in it, there needs to be man in it, and mental health somehow. And I said, great. Okay, that was the one thing. And so it was a little bit destiny also,
Okay.
because I had natural inclination also to research. Then afterwards, what became my main topic, like man's depression and also like testosterone levels, etc., and how they interact. As my father, he definitely had, looking back, depression for a long time, which was not recognized. And unfortunately, he didn't seek out treatment, and it got so bad that he attempted suicide.
Mm.
And then he landed in a clinic, and for quite some time, he was there in this clinic until he actually died because of the long-term consequences of the suicide attempt. So this was when I was like a teenager,
Okay.
and during my PhD, I get the possibility to research man's mental health, and I think that was it. That was the starting point. That was maybe destiny. I don't know.
Okay.
And then I could really follow this natural interest of mine to understand how this vulnerable group of men that is not able to reach out, unfortunately, although there might be so many good things in their lives, etc., to really become better. And I wanted to understand it better. And now, at the point where I am right now, to change it. So the first part was, I guess, understanding, see what is it for a good part. I think also there was my interest in sex differences, like the biological differences, which there are. I mean, like that men, for example, have 6 to 7 times higher testosterone levels as women. And might this be like a risk factor, or is it even a protective factor, or what's going on there? And that men, for example, in stress tests, like there's very standardized the 3-year social stress test, where you have like to give a mock job interview in front of a panel, and to do you have also to do a mental error arithmetic task, and it's very stressful. And the men usually report that they have lower stress levels, but they have higher cortisol stress responses
Hmm.
as compared to women, where women, like they say, they're super stressed, but they have lower cortisol stress responses.
Oh, okay. I didn't know. I wasn't aware of that. Interesting.
It's a very interesting finding. Yes, this also left me wondering, is there like a biological basis for certain mental disorders in men, etc.? And I see in the data that the biological differences are there, but they are not as relevant as the psychological differences, where we then go on to traditional masculinity ideologies and so forth, I guess. So this is the whole spectrum where how I got here. So it was a little bit of destiny, I would say,
Yeah.
my past, then the choice of my supervisor to give me a topic that was perfectly aligned with the past and my interests to delve into it. And yeah, the combination of biology and also social cultural norms.
Yeah. Curious about that with you. You said you're going into your doctoral studies. You had an understanding of this supervisor of yours who did this work on women, and you came in, and it sounded like she said, "Okay, now I want to shift and do this work on men." I'm wondering for you, were you expecting that you were going to do one thing with her, and then she said, "Nope, we're going to do this thing now"? Was that like you talked about it like that was something you were like, all right, let's go, I'm interested in this, but was that like the- the word I think it was kind of a blind side, like something kind of comes from the side, you don't see it coming, were you like, oh, I didn't see this coming, I got to rethink this? I don't know, what was that like to have your supervisor say, nope, we're going to do this now instead?
I had a slight idea that she was planning something like this, because right before that, I was working at her lab already for a study in the armed forces of Switzerland.
Mm,
So we're
yeah.
doing like stress tests
Yeah.
and mental health assessments in the armed forces. And I thought that there might be a change.
You had a little
Sorry.
indication like that a change may be coming.
Yeah. So I wasn't completely unprepared, but I was even happier knowing that I had like a very wide range where I could look for my interests.
Okay. Yeah, so you were talking a little bit about like that you're intrigued by biological factors, psychological factors kind of influencing men and stress response and things like that. It sounds like at some point in time you became interested in depression in men, looking at depression in men. Tell me how that came about, where you started to study or investigate depression in men.
Actually, a funny story, because I was funded by a grant that was actually investigating the dynamics of healthy aging.
Okay.
So I was supposed to investigate health and what maintains health, as opposed to what leads to depression.
Mm,
And because of my natural tendency to be more interested in what what leads to depression and how can we support men to avert it, I always shifted in this direction, and this led to a quite an intense moment between me and my supervisor, when she said, "You're supposed to do that," and I was like, "Yeah, but my thing is this direction,"
yeah.
and
Yeah.
so it was a little bit of fallout there, and I realized I need to research more men's mental health, with the goal to understand mental health and support men that are in need, and to develop therapies, etc. We will talk about this later. So this was an interesting start because it was actually supposed to be more what leads or what are the factors that help men stay healthy
Yeah.
over the course of their life.
Yeah.
And that was more, what can we do to lift up the ones that aren't healthy anymore?
Yeah. So wasn't an, I think if I hear you right, that's not what you were initially looking to find, was looking at men and depression and studying that, learning more about that, thinking about how to treat it. But it's something you came across and it caught your interest and then became an area of focus for you.
Absolutely, because we started to investigate men 40 years and older, and men 40 years and older, they start to have an annual decline of testosterone levels
Mm,
by 1 to 3% per year.
okay.
And we wanted to understand if this also leads to psychological changes. So are there any correlates with that? And obviously we saw a slight association between reduction of sex hormones such as testosterone and a slight increase in depression levels.
Mm,
So that there is a relation. And this was again a spark that left me, okay, and how is it in depressed men? Do depressed men have super low testosterone levels, or is this just not there? And questions like this arose from there.
got it. So that's, I think if I hear you right, that piqued your interest at looking at this depression. How much is it related to masculinity, psychological factors? How much maybe is it due to testosterone levels in these
Exactly.
men
The
specifically?
masculinity part wasn't in there in the beginning. The
Ah,
masculinity
okay.
there. So we weren't looking at traditional masculinity ideologies. We weren't looking at what is manhood, how should we
Okay.
define it, etc. Or what is masculinity. We were really like, what are the biological basis of mental health in men,
Yeah.
and how do they change with changing hormone levels? Because as I told you, I come from a stress lab where like stress hormones were playing a major role, and they tend to increase in age,
Yeah.
and sex hormones tend to decrease. And so we wanted to see, are these changing hormone levels related to any psychological changes as well? And we've found some correlations, etc., and some associations there, but they were never as strong as then later on when we included also masculinity measures in our studies. When I started to check, okay, is it more the biological aspect, or is it more the social cultural aspect of traditional masculinity that leads to depression symptoms? And this was interesting to see that it's always the social cultural variables were always explaining much more variance than the
Mm.
biological variables for mental health aspects.
So as we continue the conversation, and it's super fascinating for me. As we continue the conversation, might be helpful to like pause for just a minute, think about depression. So when you're talking about depression in men, it's like you're talking about depression symptoms in men and testosterone levels, and then looking forward, I think we'll talk about your treatment that you're investigating in men. So when you're talking about depressive symptoms and testosterone, are you talking about like typical depressive symptoms like sadness, down, blue, and like lack of pleasure, that kind of stuff?
Yeah, in the beginning, it was exactly that. So,
Okay.
um, I mean, like testosterone is an anabolic hormone, also that many bodybuilders use it to
Yeah.
like support their bodybuilding, and you have a better body composition, and also, I mean, like if you take it, you have a higher libido, and so the aspect of vitality, if you take everything together, yeah, it merges together to the aspect of vitality. And so this was the center of the relationship between testosterone and mental health. Higher testosterone levels, more vitality; lower testosterone levels, lower vitality. And as vitality is low in depression, the link was relatively clear there. So we assumed that there must be a relationship, and scholars have investigated this before, obviously. And we wanted to see if there's like a direct link in the change of certain hormone levels in the natural decline, and the mental health correlates. So this was interesting. Testosterone itself, I then went on to see if there's like differences in depressed and non-depressed men in their testosterone levels. And it's not as clear as one might assume from the outset.
Okay.
And there's many things that we need to consider there, because testosterone is, yeah, a hormone that is like all over the place, and it's influencing a lot of different aspects in our lives. Like, as I said, this libido, body composition. Obviously, there were some rumors about influencing cognition. So we need to consider some aspects, and also the biology of it. You need to have like the receptors, the androgen receptors that are like distributed in all of your body where testosterone needs to act. And they might be more sensitive or less sensitive. So the absolute levels sometimes are not even that important. So if you have super sensitive hormone receptors, then you don't need the very high amount of testosterone to elicit the same effect as lower amounts or higher amounts if you have a very not sensitive receptor. So this is also something that I needed to learn. The absolute amount of hormone in your system is not predictive of anything. You need to consider also, for example, the availability, the frequency, and the sensitivity of receptors. And we also try to measure that, because there are certain genetic differences in the androgen receptor gene that you can measure. But also it's quite a difficult task there to get really a
Yeah.
clear picture to say this and this is the holy grail in the end. So
Yeah, it sounds quite complex to try and isolate like what is the thing potentially that's getting at that association, right, between like testosterone and depression.
exactly. And that's where my frustration was rooted a little bit. So we set out to do a meta-analysis of the effects of testosterone treatment in men. And there we saw, okay, if you like in I think there were included 18 or 20 randomized clinical trials.
Okay.
Uh, and we saw, if you supplement testosterone to men, no matter if they're like eugonadal, like normal testosterone levels, like every man outside, or hypogonadal with like an endocrine disorder
Mm.
that
Hmm.
they have really low testosterone levels below 12.1 nanomoles per liter, they have a positive effect on mood. So if you give men testosterone, it has a mood improvement effect there.
Okay.
So you reduce depressive symptoms, but it's, again, the effect was comparable to antidepressants, but it's a much smaller sample size as compared to other huge meta-analyses that investigate antidepressants out there. And there's also not that much interest in making testosterone, for example, available as
Yeah.
a alternative treatment, because you
Treatment.
have no patent anymore. So you cannot sell testosterone as at the high price, because everybody can produce testosterone. And so you cannot sell it very, very expensively. And so it's not a very interesting thing for the pharma companies to say, okay, testosterone is a viable antidepressant alternative, and if you want, you can try.
When did you become interested in a psychotherapeutic treatment? That sounds like a little bit like kind of outside of the scope of what we've talked about so far with your research background and your training background. And when did that become something that you wanted to do or develop, and why?
Absolutely. As soon as I started to delve into this literature of man, depression, but then I realized there's a very interesting section of the literature, like saying, okay, there might be like this under-recognized form of depression, male depression, that is not expressed with the typical depression symptoms. And I thought, okay, this is something that we need to investigate as well. And as I never understood why men should have only half as much depression as women, because that's what the prevalence rates tell us in the large international
Yeah.
epidemiological studies.
Yeah.
I was like, why? From other studies, we know that men have the same level of psychological distress as women. And yeah, men have also more alcohol use disorders, and also unfortunately die more often, much more often by suicide
Yeah.
as women. It was always clear to me, but death by suicide, alcohol use disorder, what is before that, right?
Yeah.
It's the depression, and it's the unrecognized depression in men. And so there was the thing, the relation to my father's sad story, that nobody saw that there was a depression
Mm.
before his suicide attempt, where I was, okay, this makes complete sense, and we need to further investigate that. And fortunately, there were like great scholars before me that already started this path, right? And I was very happy to then stumble over Simon Rice's male depression risk scale,
Yeah.
that like made it available for the large research community to have a measure for that, at least to say, okay, we try to capture this male typical externalizing depression
Yeah.
symptoms that are not the typical anhedonia and depressive mood symptoms, but instead riskful behavior, anger and aggression, substance use, somatization also. I immediately recognized it with looking back in my father's past, right? And
Yeah.
so, okay, this was there, everything of it. And there's some truth to it that we need to make available for all, first the research community, but then also the practitioners, because they don't know. They lose many important cases by not recognizing them and
Sure.
giving the wrong treatments, and
Yeah.
then in families suffering from misdiagnosis and mistreatment in the end. So I immediately catched fire when I read about it, and I also then used it in my studies to see, okay, is there more what is actually explaining more of the variance of depression in men? Is it more the biological basis? Are there lower testosterone levels that are like responsible for it, or is there more like the stress hormones, the cortisol aspect? Even we measured inflammation, we measured everything, and also like masculinities. And they just explained a lot of variants. And then I was like, okay, there's something very powerful there.
Yeah.
And we need to consider that, and we need to use that to help the man.
So the a big part of this was looking at what's happening here, what's explaining the variance, what's explaining what's happening here. And then yeah, also I think so many researchers have that experience of the personal and the professional merge, right? Of my
Yeah,
personal
and
experience informs, what I'm passionate about researching.
absolutely. And it wasn't without complications, because as I told you, I came from a stress lab and from a very psychobiology focused lab. And then I started to say, okay, but I want to investigate men's depression. And I'm just in the models, I'm just putting all the variables in and checking what is really having an explanatory value here. And it was the masculinities. Obviously, it
Mm.
was future past behavior, like if you had like depression already in your history, etc. This always explains present depression, stuff like this. But the conformity to traditional masculinity ideologies or related variables explain so much that I really then had to defend here in the lab, and also why I'm now also going on this track to more and more research that, and to say, and to really just switch gears a little bit from
Yeah.
uh, bio biology focused, or I wanted to understand the biological basis of certain mental disorders, and then to go, no, okay, the biology is important, but here for this phenomenon, we definitely need to consider more also this variable that we haven't like looked at all so far.
So let me ask you a question about this. I think we're more and more used to this idea of tailored treatments. You think of like a empirically supported treatment for depression, right? Or empirically supported treatment for anxiety. You match the treatment to the symptoms. But I'm wondering a little bit with like this even seems like a more tailored treatment where we've got a male specific depression treatment. So it's not just tailored for depression, but it has this gender tailoring too. I guess that's how I'm kind of imagining it. So maybe you can help people understand a little bit like what's like a male specific depression treatment? What's the male piece that is integrated in there? I'm curious about it.
Absolutely. I think I was so astonished when I realized we were always talking about, okay, we need precision mental health or like precision medicine, and we need to tailor treatments. And what are the most defining demographic variables that we have? Age and sex. And why is sex so important? Because there's not only the biological aspect of it, but also the social cultural, right?
Sure.
And so I couldn't understand that we were talking about, okay, we need precision medicine, but we do not even manage to adapt our treatments to this main demographics, right? There was a huge group here also in Zurich. They are also working with elderly people. And so they were working also on developing treatments for more elderly people, the
Yeah.
geriatric track, and also the children and adolescent section is also big here, right? So the age thing was covered
Sure.
in that sense, but
Yeah.
my supervisor during the doctorate, she was doing a lot on women and women's health and pregnancy and menopause, and also tailoring treatments there, like for postpartum depression, etc. So okay, there we are. But there's one group just left behind, right? And that was my thing. I thought, okay, there needs to be something more tailored because men, especially in the mental health area, just take a little bit different. There's more self-stigma. There's more hesitation, more reluctance. The presentation of the symptoms, as we already spoke, can be different.
Yeah.
I always say, in the end, if depression is full blown and we are on the lowest points of low points, then the depression in men and in women is very comparable. But at the beginning, where you can interfere the most and also maybe have the biggest impact in even preventing maybe a depression, there it looks very different. Men in the beginning tend to mask or to hide or to not acknowledge the depression themselves, right? So they are more stressed, they're more irritable, they're like acting out more, and nobody understands that they're actually super alone and overwhelmed and actually begging that somebody sees their pain, right? It's something that I also see in therapy sessions with men, that when you start to talk about felt pain and hurt and difficult situations, it just boils up so much emotions because they never had the chance to really say, okay, yeah, there I was just like left alone with this problem because everybody thought I'm a boy or I'm a young man. I need to deal with this and I need to handle this. But I was super overwhelmed and I was blocked and I felt super alone. So there's this feeling that there's so many things because of the gender, like the male gender, that they have to do on their own, and they feel maybe overwhelmed, that in a therapy it can come up, it can come to the surface.
If I hear you right, are components like that integrated into like a male specific treatment where there's this idea of the symptoms may look different, that it may be that maybe their pain may be masked and they need to understand that, or that the therapist may need to be patient as it goes from like the underneath the surface to the surface. Are those things that you're thinking about more conceptually, or those things that are actually integrated into like a male specific depression treatment?
They're absolutely integrated. That's what we try. We try because there's this whole literature of the psychology of man and masculinities from the last, I don't know, 30 years, 40 years even, which has never found entrance into the clinical work of the practitioners here to any degree. It was just like left out, right? And so only with you and other researchers like Simon Rice, Zach Seidler, John Ogrodnichuk, etc., they tried to bring it in somehow. For me, it was super important to take all the literature and integrate it into a really systematized therapy that we have a manual for now that we can apply and see if it's more effective than the gold standard CBT therapy, right? What we did there is take all this knowledge and give it to the man somehow in psychoeducation form, but also in exercises like identify your emotions, and then they need to say, okay, I have this and this emotions and this symptoms, for example. How does this look like? Who would have this? Is this and a woman with a depression, how would this present itself? And then it was, that's different. Is it like two sides of the same coin? And then they do like exercises on this and realize, okay, do I also have like these feelings of anhedonia and depressive mood when I'm alone at home and when I let the TV on so I don't need to engage with my depressed feelings? And they realize, okay, I actually can let go of this more externalizing depression symptoms like anger, aggression, substance use, etc., and tap into the more prototypical ones where the classic therapy was developed for, right? But you need to uncover this aspect first so you can treat in a more effective way. So that's actually our idea behind it. We try to psychoeducate the man about all what we just talked about, right? Man, masculinities, how the gender role socialization leads men to more avoid feelings and only express as negative feelings anger and aggression, and definitely not shame, guilt, the depressive symptoms, etc., because this is not manly, right? So they learn, oh, I was taught the same, and that's why maybe I cannot really tap into these emotions right now, but maybe it would do me quite good.
Yeah.
And we have this very little study that we just published now in Psychotherapy Research, where we just evaluated a male-specific psychoeducation in an online version, where we just saw 75 men read, they had like questionnaires, pre and post, and in the middle, the experiment was 7-minute long psychoeducation text. Very ugly. It was just plain words. And the one was a male-specific one with all that we talked about, including also psychoeducation about depression. And the other one was like a gold standard CBT psychoeducation text, explaining prevalence rates, the depression symptoms, and also the treatment options, etc. And afterwards, the man that had the male-specific psychoeducation, immediately after this 7-8 minutes reading, they had a reduction in state shame and negative effect as compared to the gold standard CBT.
Okay, that's
So
fascinating.
they showed immediately they had a reduction of shame and a reduction of negative effect by just understanding, I'm a man and I'm actually allowed to feel these negative feelings, like to have these depressive feelings, and I don't need to cover it anymore, and this is exactly me. And it elicited something. And the other thing that is also interesting is it wasn't statistically significant, but it was like very strong in this direction, that the male typical externalizing depression symptoms in the male specific condition went down, and the prototypical seemed to go up a little bit. It was like just 10 minutes, right, before and after, where they had to do twice the questionnaire. So it was for us the indication that they really can let go more of this male typical externalizing symptoms and more acknowledge and recognize the prototypical symptoms, because obviously somebody, this text, understands what they're feeling. And if you do this in a psychotherapy setting with exercises, with worksheets that you give them, and they should go home, etc., and work on them over a longer time period, you open them up for therapy, then they're more engaged, because we also know that men are like they tend to prematurely and terminate psychotherapy. And sometimes they're also reluctant to fully engage in psychotherapy,
Yeah.
because in therapy, you need to show yourself vulnerable. You have to let control go a little bit, right?
Yeah.
This is stuff that this traditional masculinity ideologies say, no, don't do that. Stay in control, be dominant, definitely don't show any emotions, right? This is all terrible for psychotherapy. And so we try to weaken that or soften this
Yeah.
so that psychotherapy in the end is more effective. And if it works or not, I can only tell you like in a year, and then we can do a next podcast, I guess. But
I
the
love it.
clinical trial is running.
Yeah, it's really interesting. Yeah, I recently had a conversation with Aaron Rockland, and he was talking about, there's these different terms of what is this depression that some men feel externalizing? Is it masked? Is it male? And he was talking about he kind of likes the mass depression term, the idea of there's this thing and then these externalizing symptoms, they kind of mask it. They're kind of on top of the underlying pain. And it's a bit of what I hear you talking about, Andreas, with
It's
the fr
conflated, right? It's conflated because is it masked? Is it masking it? Or is it the actual depression, right? So uh, we're not there yet. It's a dilemma also, because we have clear diagnostic criteria for a certain disorder, which is called depression, right? And we cannot simply go there and say, okay, we change the criteria right now for a subgroup
yeah.
of patients. But we also need to acknowledge there seems to be going on something with men. And maybe it's masking symptoms, or maybe it's just like the expression because of our gender role socialization.
But it's interesting to hear you. I think talk about the framework that I think I heard you talk about with the your treatment with we can get at these more externalizing kind of symptoms if we can kind of get at those, and then once you kind of said loosen those up or treat those or help them understand those, then underneath those is like the pain or the typical depression, right? And so then you can target that after you get underneath the externalizing symptoms. And it's interesting to hear you talk about that framework for this treatment.
Yeah.
It makes me think of that kind of mass type of approach. So this has been great. So this has been really fascinating for me. And yeah, of course, I want to know about, yeah, what do you find? How does it compare to CBT? How does it compare to testosterone and things like that? And it'll be great to know more about that. So I think people will be interested in learning more about this, this work that you're doing, and whether it's male specific treatment for depression. I think people will, people like me who are, my background is all about like the masculinities and the social cultural piece. People might be interested in testosterone now. They might be quite curious about this because they might not have that background. What are some things, resources, some recommendations that you might have based on your work, whether it's in depression, masculinities, etc., that you would recommend people seek out that have been meaningful for you or that you think they might find interesting?
For the link between men's depression, testosterone, and masculinities, there is nothing. That's
Hmm.
that's the point here. Nobody's looking at this so far,
So
because
it's just you.
I feel a little bit lonely here. Yes, because it's really like we always say that we need to be like collaborating with different fields, right?
Yeah.
But who actually does it, right? So you need to collaborate with people that really understand the biology, that really understand medicine, psychiatry, and psychology. And it's quite an intersection there. Um, what I'm doing, for example, is in the clinical trial, obviously we have a neurologist, or he's also like saying that his clinic is a urology andrology clinic.
Yeah.
And, he's doing all the testosterone assessments, and in case there are like testosterone treatments as well. And so we have much literature about hypogonadism. and testosterone treatment and testosterone treatment for depression. But there's not an actual book that really combines also then the aspect of masculinity. So there is like pioneering work from our side that we're trying to combine those things.
Okay. Is there anybody else, that if people are interested in this male specific depression treatment and they want to look more into something like that, are there resources or other people who are doing that work? People are like, I want to learn more about that. Like whether it's your work or other people's work, can people find out more about like what that is and what that looks like?
I can recommend our publications. Most of them are open access, and also, as I already mentioned briefly before, Zach Seidler is doing an amazing project also with Men in Mind to help mental health practitioners evolve in their understanding of men and masculinities and the treatment of men. And I think this is really from our side's pioneer work, where we really give like in my case, a systematized therapy approach to treat depression in men. So this has not been done before, and that's why it's a world's first, and we need to see if it's worth all the effort, right? So next year, if we analyze the data and we see there's no difference, then I can come here and say, okay, it was a big project and we learned that, but there was no superiority of this as compared to CBT. I would be quite disappointed, obviously, but the data is the data in the end. If we, on the other side, see, okay, for example, in the reduction of shame or in the reduction of guilt or actually depressive symptoms, we achieve the same effect much faster, for example. Oh, also good,
Yeah.
good find. Or even there's like really a clinically meaningful difference in the outcome assessment, and then we say,
Yeah.
okay, this might be really something that is worth pursuing because we see that there's a superior effect, and that is open until we have the data, right? So I'm blinded. I'm not doing any outcome assessments. I don't have access to the data, so I am completely blind for now, and hope to have like some very interesting data next year. And at least what we will see is also what I'm quite interested in is seeing if the conformity or the endorsement of traditional masculinity ideology changes over the course of the treatment, because
Mm.
this is something that we actually directly target because we identify it as a risk factor, right?
Mm.
Because we saw that conformity to traditional masculinity ideologies, to all these subdimensions of, I always compress them to be in control and be unlike women. These are like the overarching main topics, right? And then you have many subscales in this instruments. But we actually target this with our psychoeducation, with the exercises that we do. We try to soften it and to reevaluate masculinity. And it's also a little bit a discussion of if we should call it like a deconstruction or a reconstruction of masculinity. And obviously, we have also exercises to present new forms of masculinity for the individual man and what he wants to be in the end, like, or what his masculinity should look like or should be like.
Mm.
And there, I want to see also if this 18 session, weekly session psychotherapy treatment actually changes the endorsement or conformity of traditional masculinity ideologies, because we know from longitudinal studies that these are more trait-like factors, right? So you don't change that so quickly. And also in our psychoeducation pilot trial, that was only an online intervention, there was no change in endorsement of traditional masculinity ideology, because although we gave the information about traditional masculinity ideology, just a little text reading that for 8 minutes doesn't change it. The shame went down, negative effect went down, but not this one. And so we are quite interested if this is like if this changes or changes in a certain direction that we didn't anticipate before, maybe. This is definitely something that we also are going to check. What we also will be analyzing is, for example, we have certain measures for example, childhood maltreatment, and we want to see if there's like also a beneficial effect there, because we have also data that, for example, men with childhood maltreatment have a stronger conformity to traditional masculinity ideology.
Hmm.
And we believe that this is like a compensatory mechanism, that maybe you have suffered so much and experienced a lot of shame, which is definitely not in the masculine realm, right? And then there's like an overcompensation that you need to endorse and traditional masculinity ideology so much that you show yourself and the outside that you're definitely masculine, although you had like moments that you were like overwhelmed by childhood maltreatment or stuff like this. So this is also something that we are looking at, and we want to see if our therapy works there and supports this man equally good, or if it's even better, or if it's like necessary to implement maybe also an additional component for this man where you address more the traumatic aspect.
That was really helpful, Andreas. One piece where it sounds like in this gender specific treatment where a target of the treatment is masculine norms. You talked about this reevaluation, deconstruction, reconstruction, right? So it's not even like kind of a passive consideration of norms. It's like it sounds like a very active targeting to help these guys understand what masculinities are and think about what they look like for them, how that might be related to their symptoms. And that
Exactly.
was really interesting. Go ahead, sorry.
Yeah, it's exactly this. It's not that we want to change something with brute force and say, hey, this is bad and you need to
Mm,
now consider something else. That's not what we're doing. We're actually giving the man a wider repertoire of behavioral dispositions, right? If you're like in a sports group and you need to compete against other teams, you need to be at certain moments super competitive, determined, and also
sure.
maybe even dominant,
Yeah.
which is a good thing, right? But if you're then married also at the same time and you have relationship problems, and then you also think that you need always to be dominant and not responsive to the needs of your partner, then it's a very dysfunctional situation to be like these traditional masculinities. And that's what we try. We try to open up the possibility of behavioral responses, so that there may, or the man might be more flexible to say, okay, this now I learned in therapy, maybe I will just apply this. One important point is, usually in all the depression treatments, you also provide social skills training, right? So
Mm, hmm.
you work with the patients on their social skills and their interactions. And we find it very helpful with the man, like to work with the Kiesler circle, where you just like explain the man that if they, for example, always communicate in a friendly, dominant way, that they will always elicit submissive, friendly responses, and that maybe these people are not even they don't feel secure enough to
Yeah.
really tell their needs, or the other way around. If they
Yeah.
are always in the friendly, submissive corner, that their needs are always like stumbled over, and they cannot really fulfill or even communicate their needs. And so we also tailor this to men, these interventions. And this is very helpful, that they start to understand, okay, masculinity is like all over the place. It's not just in my behavior, it's in my communication,
Yeah.
it's in the way I wake up and decide to do the dishwasher or to go and whatever. So it's very interesting when the man also starts to be in this process of reflecting this and
Yeah.
saying, okay, I really want to change some things here, and I want to start here. And this part I don't want to touch. and then they don't need to touch it. That's the good
Yeah.
thing here. So we really leave it open. It's for them to decide where they want to go. As in every psychotherapy, the client is usually the captain on board and says, okay, I want to change this here, and I want to really modify this, and this is something that I actually like, and it's good like this. So, well, then we go there. So it's giving the possibility to change masculinities and to see where or how they are related to their mental health situation.
This has been extremely helpful, extremely interesting to really take a deep dive into your process and into this treatment. I've learned so much. It was great
Thank
to
you.
connect and talk with you, and I hope you have a good evening. Bye bye.
Perfect. Bye bye.
Hi, everyone. This is Matt, just dropping in to say thanks for taking the time to listen to this episode of Inside Men's Mental Health. Do you have ideas for future episodes or feedback on current episodes? Please feel free to reach out to me at inside.mensmentalhealth@gmail.com. That's inside.mensmentalhealth@gmail.com. inside.mensmentalhealth@gmail.com. Take care, and again, thanks so much for listening.